And just want to thank everybody for coming back in person. It's really exciting to be here. It's nice to see new faces and old faces and be able to interact. I know there are a lot of folks still in the exhibit hall, which is also great, but I'm sure folks are going to be coming in as we move on. Let me introduce Dr. Subhash Banerjee, my co-moderator here, and the panel. We have Dr. Benjamin Colvard, Dr. Dmitriy Feldman, Dr. Alec Farber, Dr. Sahil Parikh, Dr. Chris Metzger, Dr. Professor Thomas Zeller, and Dr. Ramon Varcoe. Our first presentation, Subhash, I think we should get into it because of the time. And you know we want to have a lot of this discussion. The first presentation is Post-Dissection Endorepair of the Thoracoabdominal Aorta by Dr. Benjamin Colvard from University Hospitals. Thanks, Ben. And there is a timer now, so hopefully we should be in a good shape.
Okay, thank you very much.
You can use the clicker and the green button to advance.
Next.
That's the wrong presentation. We need Dr. Benjamin Colvard. You have the second presentation, Dmitriy Feldman. We need Dr. Benjamin Colvard on the...
It's like a Russian roulette of talks. You just get whatever comes up.
And please run his timer because, you know, there's nothing we can... I'm just kidding. Let me take a moment to, I know we have our faculty here and our team, you know, it has been, I know many of us are having challenges with the staffing in our hospitals, with the nursing and other. As you know, the hotel industry is also struggling with that. We have had some challenges in the last day and a half with some of the ancillary support, so I apologize to the faculty and to some of our team members if they have had any struggles. It's nice to be back. We're going to do this and get this done, but I'm sorry for some of the delays like we are seeing right now.
Just a message for the AV team at the back. If it is, would you like us to move to the second talk and do Dr. Colvard's later? Is that something? Let's do that.
Sure.
Let's do that. So Ben, you have a seat, and we'll invite Dr. Dmitriy Feldman. I think his charge is to talk about covered stents for aortoiliac intervention. So Ben, let's see. Ben, you'll be next, hopefully, and then Dmitry, I hope you don't mind giving you the surprise, but you're a pro. You can do this.
Not at all. Not at all. And thank you once again to the organizers and the moderators for inviting me. I will be covering the covered stents for aortoiliac interventions in this talk. I don't have any relevant disclosures. Let's see. So as we all know, there's been a tremendous evolution of cardiovascular devices in the periphery, and this has been in the iliac vascular beds as well. We treat task A through task D lesions, and as many operators around this table and in the room, there's more and more frequency of tackling complex task C and D lesions. So we need to understand, we need to know the equipment that we have. And so in the iliac intervention specifically, we have a number of potential stents that are available. There are balloon expandable stents, which offer precise deployment and radial force, commonly used in the common iliac arteries. There are self-expanding stents with flexibility and deliverability in multiple sizes. Commonly we use them in external iliacs. And then we have covered stents. So initially they've been used for bailout treatments of arterial perforations. They're commonly used to exclude thrombus and aneurysms. And it's important because the covered stent prevent the neoantimal hyperplasia. That comes with that is that you may need to use antiplatelet therapies a little bit longer, but these stents are associated with decrease in hyperplasia and restenosis. We have 4 types of covered stents available: iCast, the VBX stent graft, the Viabond, and the Livestream, and I'll touch a little bit on each individual system. What you need to know about covered stents is you need to plan your strategy in advance. So here is a common iliac osteal disease. You need to understand your access. You need to understand which stents, what size, properly size them, and that will determine your access sheaths as well. So in this case, for instance, a 9mm stents were used, so 7 French bilateral system was needed. If you wanted to use 10 or 12mm stents, then you would need at least an 8 French system. So where's the data for the covered stent? The randomized data comes from the older COBAS trial. This was 168 iliac arteries, task B through D classification with a stent, ICAS stent that is a balloon expandable stent with an inner and outer layer of PTFE material. The outcomes were better with covered stents overall, but particularly improved outcomes with task C and task D lesions. We now have longer-term follow-up, up to 5 years, with improved patency with covered stents. Here's just briefly 18-month data, looked better for the covered stents, but impressive outcome improvement with task C and D lesions. The VBX stent graft, this is a balloon extendable covered stent. The FDA approved in 2017 for treatment of de novo and restenotic lesions. We have data from the VBX multi-center single arm study, 134 patients. These are real live patients with CTOs, calcified disease, tortuous disease, and in task C and D lesions, a 9-month patency was quite impressive, 95%. And now we have 3-year data with 90% freedom from TLR, 98% freedom from clinically driven TLR. And this has been confirmed now in registry studies, over 200 patients, real-life patients with a lot of chronic total occlusions, about 40%, 20% instant restenosis, calcified lesions, and once again, we're seeing primary patency rates at 12 months over 90%. And what this allows us to do is individualize. So for patients who have distal aortic disease and osteoiliac disease, we now can create a complex procedures like syrup technique where you put a large covered stent in the distal aorta, you have to expand it, proximally optimize the proximal edge, and then kissing stents in the osteal bilateral iliacs. In a way, you're creating a manufactured EVAR type of device with your covered stents. But you're going to need a large bore access, bilateral access. Viabon endoprosthesis, a self-expanding stent with nitinol support, FDA approved for treatment of symptomatic iliac artery lesions. This is a prospective study of 60 iliac arteries and outcomes at 98% with 91% at 12 months primary patency. You need to know which lesions to use it. You need to size them appropriately. This is commonly used for the common femoral and external iliac arteries. The Livestream stent is a balloon expandable covered stent, recently approved in the US, stainless steel with encapsulated between 2 stretch PTFE layers. Also was studied in the Bolster study, 155 patients, good 9-month patency of about 90%. We've had a number of meta-analyses compared covered stent versus non-covered stent. This is Aaron Armstrong's study of 47 individual trials. And overall, we're seeing that there's a benefit in terms of restenosis, in terms of primary patency, particularly in the complex task C and D lesions. What about the guidelines? Well, we have now many authors at the table who've participated in the 2020 SKY guidelines for device selection. This is looking at comprehensive review of available devices for aortoiliac intervention, so covered stents, balloon expandable, self-expanding stents, etc. They take into account the efficacy of devices as well as perhaps the cost as a secondary measure and provide clinicians with guidance with specific class of recommendation and level of evidence for each individual device type. So here's a table example of covered balloon expandable stents on the left and covered self-expanding stents on the right. So as an example, aortoiliac bifurcated stents get a class 1 recommendation with level of evidence B. So you can use these kind of documents to guide you. This is guidance documents. They don't mean to tell you which stent to use for which lesion, but generally you will understand which stents and where the data are. So, in conclusion, peripheral interventions are very effective for patients with lifestyle-limiting claudication and hemodynamically significant aortoiliac disease. Covered stents, especially balloon expandable stents, can be used in treatment of complex calcified iliac lesions, task C, task D, aortoiliac lesions. Covered stents should be used selectively to prevent and treat iliac artery perforations and excluding thrombus and arterial aneurysms. You have to understand that you might need to use longer dual antiplatelet therapy with covered stents. And we do have some guideline documents from our societies to give guidance with specific recommendation, class of recommendation, and level of evidence for aortoiliac device selections when these devices are needed. Thank you.
Thank you. Thank you so much, Dr. Feldman. That was a fantastic overview. Do we have the presentation of Dr. Colvard, our first presenter? Yes. Okay, Dr. Colvard, please. Thank you so much. Again, he's going to be discussing post-dissection endorepair of thoracoabdominal aorta.
Thank you, Mehdi. Okay, so we'll take a little detour from the PAD world into the dissection world here. You guys have my slides?
Gentlemen, is it going to come up? Okay. I think we need a little bit better AV support. This is quite disappointing.
So I'll just make a comment on the last talk with covered stent. I've moved more and more towards using covered stents as my first line approach. I think it's always easier to put in a covered stent in a controlled manner than to be flailing and trying to fix a rupture. So especially the more calcified it is, the lower my threshold is to just use a covered stent in general. Okay. All right, here we go. So thank you for the opportunity to present on this topic today. These are my disclosures. So the objective this morning is to discuss two specific techniques for treatment of false lumen aneurysms related to type B aortic dissections, and to discuss when to use these two techniques, Knickerbocker and candy plug techniques. So first case is a 63-year-old gentleman. Mainly his issue was with hypertension. He had a type A aortic dissection in March of 2018, and at that time he had an ascending aortic repair with a hemiarch replacement, and then he was followed closely for his residual type B aortic dissection. So looking at his CT scan, and we know that there are certain features that put someone at high risk for late degeneration and complications down the road after type B dissection, including patients who have partial thrombosis of the false lumen, a large diameter greater than 4 centimeters, false lumen greater than 22 millimeters, and an entry tear greater than 1 centimeter or located at the distal aortic arch. In this case, the patient had 2 of these high-risk features, so he was followed very closely following his type A repair. So sure enough, in surveillance imaging, he was noted to have significant growth at the distal arch and proximal descending thoracic aorta. Within 10 months, about 1.5 centimeters of growth. So we took him for an elective repair of this residual dissection. And because he had a prior type A repair and the dissection was extending into the arch, we elected to do a debranching of the head vessels. So we call this central debranching, and that allows for a zone 0 TVAR extending into the ascending prior graft. In this patient, we wanted to exclude flow in the false lumen. So that means we need to shut the door distally so that there's no retrograde up into the false lumen, which is the indication for treating this patient as an aneurysm of the false lumen. So we use the Knickerbocker technique in patients who have a distal seal zone that is suitable for being sealed with up to the largest available thoracic endografts, which are 45 or 46. So patients with a seal zone of greater than 4 centimeters can't really be adequately oversized with TEVAR devices. So it's specific patients with a good distal landing zone that can have this. So he underwent central deep branching. You can see here branches to the innominate, carotid, and left subclavian, which allows us to then cover the entire arch with the endograft. Could you start those videos for me? So on the left, you can see the central debranching coming off there on the far left of the screen. So we then, the next video please, we then place a proximal piece, a 34 millimeter Navion device that goes into the, basically covering the arch and lands right up to that debranching bypass. And then coming down with a 37 millimeter diameter device, which will seal across the true and false lumens once we rupture the dissection flap with a coda balloon. So this creates, you can run that video for me. This allows the dissection to be sealed above the celiac across the entire lumen, and you can see here the flow stops right at that point where we ballooned it. So in follow-up, you can play both of these videos. In follow-up, at 2 years, the patient has excellent remodeling and no endoleak or flow into that proximal descending thoracic aneurysm. So again, a good technique when your distal landing zone is small enough that a thoracic endograft can seal across the entire aorta at the celiac artery. Candy plug technique is another trick that we can use for treating these chronic aneurysmal degenerations. This is a gentleman similar to the last one with hypertension. He presented with a type A dissection and had type A repair with a TEVAR for his residual type B dissection at that same time. He presented a year later with growth of his false lumen up to 6 centimeters. So again, we're dealing with proximal descending thoracic aortic aneurysmal degeneration. And in this case, his distal aorta was too large to be able to seal across the whole aorta with an endograft, as well as the fact that he had a prior endograft that was only up to 32 millimeters. So we can't balloon that large enough to seal across the whole aorta. So what we do here, and these are images from the lab, we were, when we first started this, we were building a bunch of candy plugs in the lab to make sure that we could do it. So this is a technique that is useful for people with larger distal thoracic aortas that need also some way to shut the door on retrograde flow into the false lumen. So in the operating room on a sterile back table, we partially deploy the endograft, usually using a stent graft with an odd number of stents. So in this case, it was a 5-seal stent device, and we cinch the middle stent down with a 4.0 or 5.0 proline. Most important part of doing this is to not cinch it down so much that you can't remove the nose cone of the delivery system. That has happened to us, and actually the bailout for that is to come up with a balloon, inflate it in that waist, and break the suture, and then place another device inside that. We use Ramel tourniquets to reconstrain the device, and you can see here, deploying the device, you can see proximally it fully expands, and we use IVUS to ensure that we're in the false lumen. We fully expand the device, and in the center cinched down wasted area, we deploy a large Amplatzer plug across that to seal the false lumen flow. So you can see on the far right is a better representative image from a different case where you can see really nicely the way the Amplatzer plug fits across the plug. Again, showing cessation of retrograde flow, nothing's getting beyond that candy plug, and in some cases you can actually go through the plug prior to putting your Amplatzer device in and place embolization materials into the false lumen if that's needed. So nice remodeling on this patient as well, with no flow in his post-dissection aneurysm there. On the far right is the other case that I was showing there with no endoleak. So the Knickerbocker and candy plug techniques are good options to consider when you need to obliterate false lumen flow in the thoracic aorta. One recommendation I think is critical is to use IVUS during these cases, because it's important to know exactly which lumen you're in. It can also help with sizing if the CT scan is not clear. and always need to be prepared for complications. Dissection can be very unpredictable. So we're always prepared with the possibility of doing distal stenting, visceral vessel target stenting, and even rarely open conversion with visceral bypasses if needed. Thank you.
Thank you, Ben. That was great, and thanks for pulling it off. And sorry for the AV issues. So let's be consistent with the theme of CVI of bringing vascular surgeon and interventionalists together. And to present our next talk, I invite my dear colleague and vascular surgeon from UT Southwestern, Dr. Shirling Tsai, to talk about frontline strategies, or best practice of the use of drug-coated balloons. Shirling, take it away. The clicker has a green button for moving slides forward.
All right, great. All right, good morning. Thank you. I want to thank the meeting organizers for inviting me and for putting this together. So I'm going to talk a little bit about the best practices use for drug-coated balloon angioplasty. I thought about this for a little while because, DCB is really just one of many things in our armamentarium to treat PAD. I have no disclosures. So studies have shown that DCB decreases the rate of restenosis. They've shown this in comparison to plain balloon angioplasty compared to bare metal stenting. And after the drama from a couple years ago, really, I think most concerns about DCB have been relatively assuaged from relatively big population-based studies in the US and in Europe. So it's kind of back in practice in some places. So I thought I'd talk a little bit about some unique technical aspects of DCB as it sort of comes back from the hiatus of not being used for a little while. So one thing is balloon preparation, which we never really think about when we do plain balloon angioplasty, but there are some idiosyncrasies to the DCB. First is this sheath that it comes with. And invariably, my scrub tech tries to take it off every time. This always happens. They're just trying to be helpful, but they always take it off, just like everything else that comes with these balloons. And then really you're supposed to leave it on because it's supposed to protect the drug on the balloon so it doesn't come off. So one thing to tell your scrub tech or your circulator, whoever's there, is please don't take it off. And when you flush the balloon, because they always try to help flush the balloon, try not to get the drug wet because the drug will come off. Then when you're inserting the drug into the balloon into the sheath, you're supposed to do it with this covered thing, which also can be a little bit annoying, but it is actually there for a reason so that the drug doesn't come off the balloon when it's going through the valve. So those are some things that we kind of don't think about, but are actually kind of important. The other thing actually mentioned in the IFU is that these balloons need a little bit longer of inflation time. Now, standing in the OR or the cath lab, especially with Dr. Banerjee, waiting for 3 minutes is difficult, okay? But it's supposed to be that way. The IFU actually does state that within 60 seconds, most of the drug has been eluted off, but it probably does take a little longer than 60 seconds for the drug to elute off and make it into the vessel wall. So, the impact takes 3 minutes. Other balloons probably take more than you think, and it's a long 3 minutes. I know this by experience. The other thing is vessel preparation. So the IFU does state that these should be pre-dilated before you use the balloon. It's not like the balloon is your primary angioplasty balloon. And there is a fair amount about vessel prep for DCB. Now, the IFUs always say pre-dilatation, but these days, vessel prep actually includes pre-dilatation, or also some people do shockwave or intravascular lithotripsy, some people do atherectomy. And these are supposed to really sort of facilitate using the balloon without having to bail out stent. So the idea is to optimize vessel dilatation while limiting risk of dissection, decrease recoil, have improved penetration of the drug into the vessel wall, and decrease the risk of drug wash-off from the balloon surface. So really all these things to sort of improve technical success. And there have been studies about this. So here is a randomized controlled trial of IVL and DCB. Patients were randomized to either IVL plus DCB or plain conventional balloon angioplasty and DCB. And this study showed that vessel prep with IVL was associated with lower incidence of residual stenosis, fewer flow-limiting dissections, and fewer number of bailout stents, but really no difference in 30-day adverse events, target lesion revascularization, or walking capacity. So no real benefit in short-term outcome, but definitely a benefit in technical success. Same with atherectomy. So people use atherectomy as the vessel prep for DCB, and this was another randomized controlled trial looking at atherectomy plus DCB versus DCB alone. Again, vessel prep with atherectomy was associated with fewer flow-limiting dissections and better technical success, but no difference in one-year outcomes. So really, I think these vessel prep techniques help us with the technical success, not necessarily the short or long-term outcomes. So here are some examples of where I think DCB has been helpful, at least to me in my practice. Here's a patient with a short segment, really occlusion of the distal superficial femoral artery. He had pretty bad runoff, single vessel. I think you need to play this video because I don't have a mouse to play it, but single vessel runoff through the anterior tibial artery. We pre-dilated with a regular balloon and then treated with a DCB, and then I think you need, can you play this video, please? The completion angiogram shows recanalization of the occluded segment with pretty good result. There's the video. So here's another case. This patient, this lady also had a distal SFA occlusion, and then, can you play this video, please? Also a pretty diseased popliteal. So if you see reconstitution of the popliteal here, and it's actually not just a diseased popliteal, but there's probably a short segment occlusion in the popliteal also, and pretty marginal runoff. It was single vessel through the posterior tibial. The posterior tibial actually went all the way to the foot, but it was single vessel, and there was maybe a twig of the anterior tibial that came back all the way down in the foot. So we tried to get across this and the antegrade direction first. That didn't quite work out. So we got access, can you play the video please? Access from the foot, and this is access into the small AT, and we decided to do that mostly so we wouldn't knock off this main runoff in the posterior tibial. We met the wires in the mid-SFA, and then we did Dr. Banerjee's favorite technique, the SFA rendezvous technique. Can you play that video, please, where we cannulated the antegrade catheter with the retrograde wire. So now we had an 014 wire through and through. And here, I think the vessel prep is actually important because it's an 014 wire that's through and through. We pre-dilated with an 014 balloon. The temptation is to try to just use the DCB here, but that doesn't quite work because the 035 balloon won't track over the 014 wire and will wash off all the drug trying to get it through the occluded segments. So we pre-dilated with the 014 balloon, then treated the popliteal and the SFA segments with DCB, and here's our completion, which shows a recanalized SFA. It should be playing by itself, but it's not. Recanalized SFA and popliteal segment with preserved runoff through the PT, which is patent all the way to the foot, and you'll have to play those videos too, please. So here's the posterior tibial, and this is, please play that also. This is patent all the way to the foot. And she had pretty significant rest pain and a tiny wound on her toe. The wound got better, and she's basically cured of her rest pain, at least for these first several months. So finally, I think there's a unique role of DCB for patients with common femoral disease, which I realize as a vascular surgeon, this is going out on a limb a little bit, but there are some patients with common femoral disease who may not do so well with common femoral endarterectomy. This is one case. This is an 89-year-old man with pretty significant coronary disease, EF of 20%, and pretty bad ischemic rest pain, and basically a very cyanotic foot. Somehow, despite all this, he still lived at home, was able to get around the house. But he did not look like someone who would tolerate a common femoral endarterectomy in any way. So we got a CAT scan. He had pretty significant common femoral disease. This is his initial angiogram, which shows pretty calcified common femoral artery there. We actually did shock wave and ballooned it with a DCB afterwards, and this was the completion angiogram, which looks much better. And if you look at his PVRs, there was a pretty significant improvement in the thigh waveform, and clinically he got much better too. His rest pain got a lot better. So here, these are just the circumstances where I think primary non-stent-based therapy is ideal if we can do it. Short focal stenosis or occlusion of the SFA or popliteal. Patients, especially with poor tibial runoff, so where you don't think the outflow will be able to support a stent. And then in those rare cases of patients who cannot get a common femoral endarterectomy, it might be something to consider. And I'll take any questions.
Thank you so much, Shirling. Thank you so much. Wonderful. This is a perfect talk of combining data with personal perspectives and techniques. Shirling already introduced the idea of vessel prep, and I think to do that further justice, I invite my dear friend from Columbia University, Professor Sahil Parikh, to talk about frontline strategies to tackle calcification. Sahil, thanks for being here.
Thank you, Subhash. Thanks for having me. I think I have my slides. There we go. Great. So I'm going to try to give you a little bit of a whirlwind on calcification treatment strategies. These are my disclosures, mostly related to investigation and advisory activities. So I think when dealing with calcium, there's several things that are important to assess up front. First, how bad the calcium is, and I'll tell you what I mean by that. And then acknowledging that some tools work better than others. And then certainly in most of our treatment algorithms, when we're treating CTOs, about a third or half the time we're subintimal for significant length, and that affects your approach. And then also, as you just heard, certain definitive therapies may benefit from different debulking strategies. And then when is good enough good enough? So just to remind everybody, the way stents work is that you need to get an acute gain with an expected late loss to get a net gain. So the adage bigger is better has been coined for the last several decades in how we approach interventional procedures. And certainly the imaging guidance that tells us the difference between lipidic and fibrotic plaque from calcific plaque is really important. And I think that as we use in the periphery IVUS predominantly, getting comfortable with understanding how, as you see on the left, intravascular ultrasound can show you this extensive arc angle of calcium is critically important. So and the reason it's important is that for the following reason. If you apply a balloon angioplasty as shown here in a calcific lesion, the path of least resistance is usually directly opposite to the arc angle of calcium. And what happens is when you have an immovable object meet a balloon, the stress is applied to the opposite wall and you get a dissection. So calcium is the enemy because it promotes dissection. And if you can get calcium fracture, you can mitigate the dissection, as you see here on the right panel where the arrow is. That thick ring of calcium is partially fractured. And if you can totally fracture it through and through, you can really expand the vessel with minimal dissection. So the goal of calcium modification is to affect calcium fracture without dissection. So again, you want to try to make sure that you use imaging, and I would advocate strongly for IVUS for peripheral interventions, so you understand when are you going to deal with that really bad calcium, the nearly concentric calcium that's going to cause you to destroy the artery when you're blowing up a balloon. Your plaque modification strategy is designed to achieve plaque fracture, and rarely is that a standalone technique. It's usually followed by a drug-eluting technology, as you just heard. So let me go through a few examples to illustrate some of these points. First is a 78-year-old man with Rutherford III claudication with a subtotal SFA occlusion. You'll see angiographically, it's sort of a ho-hum kind of a day in the life of one of us. And then you'll see a short segment focal occlusion. And sometimes these are the most vexing when you have this sort of popcorn coral reef intraluminal calcium. You can see in the unsubtracted view that there's an extensive amount of calcium. And this is sort of what I would consider my prior era strategy, which is to use an atheroablative technique like orbital to debulk the intraluminal calcium. You can see the orbital atherectomy is going around the calcium. And after doing extensive balloon angioplasty, you can see the balloon goes around the calcium, and we've got significant dissection, which we then tack up with a supera stent. And even the supera stent, which is thought to be the most rigid of all devices, goes around the calcium. And so while we got a decent angiographic and a really excellent hemodynamic result, this is not necessarily what you would hope to do. You'd like to get a better straight line debulking of calcium, so whatever technology that follows, particularly if you're not going to use a scaffold-based technology, is going to stay open. So the next case is an 85-year-old patient with a short calcific CTO where I could not even get subintimal to go around the calcium, and the patient had significant venous disease and made going retrograde relatively unappealing. So here's the lesion, and you'll see on the left there's a short CTO that reconstitutes. And this was one of those lesions where I was shocked that even despite all of my efforts, I couldn't get subintimal. And I tried a number of stiff wires, stacking catheters. I just could not get through or around it. So then I basically took a laser and I parked it on top of the cap, and I basically burned a hole through the cap with a turbo power laser that was sitting there for a number of minutes. And then finally, I realized after I got through, this is why. It was extensive 360 calcium along the entire lead pipe of the vessel, which is why I couldn't even get outside of the true lumen to get across the occlusion. Luckily, once we got through, we were able to use lithotripsy. Oops, I'm not sure why that didn't play, but trust me, it was a good result. And then here's the case where we're subintimal. It's an old patient from Brooklyn, which is synonymous with calcium, and he has bilateral fempop occlusions, the left side being the more significant, with mixed arterial and venous disease. Again, a relatively short occlusion that looks like a cupcake lesion, except there's a lot of calcium. Here's the unsubtracted fluorostore of us basically using a loop wire technique to get around the calcium. And we had a heck of a time getting back in the true lumen, such that I had to balloon the subintimal space to deliver a re-entry device so that we could re-enter. And we did get back into the true lumen. And then we had 360 calcium, except I was deeply subintimal next to the 360 calcium. And this is a situation that I find high risk for using arthroablative techniques like orbital. And so it was one of our early experiences with IVL. And you can see here's the typical balloon profile you see with the initial 4-atmosphere inflation followed by multiple pulses with good expansion. And after multiple balloon inflations and a couple of superior stents, we had a nice angiographic result. Last example is a infrapop case where we had this is an 84-year-old end-stage renal disease patient who had a non-healing wound. I'll just cut to the angios. He had pretty clean inflow, but relatively heavy, sort of Monkeberg's type of calcification of his infrapopliteal vessels, as you'd expect in a patient with end-stage renal disease. Here you see on a magged up angiogram, hopefully it'll play, that there is sort of focal eccentric calcification. Doesn't look like it should be that hard to cross, but all I could do was get a 14 wire across and nothing else would go. I used coronary CTO catheters. I used all kinds of stuff. I tried to get a laser nearby. I couldn't get the laser anywhere close. And so finally, I had to free wire it with a roto floppy wire and then use rotablator, which I don't do very frequently in the infrapopliteal circulation. But here, it seemed like the right tool. And we were finally burrow our way across with a 1.5 rotoburr. And then subsequently, we used IVL and multiple modalities to open that posterior tibial, and actually that was all he needed to heal his wound. But it was surprisingly difficult, and it was largely because of eccentric calcium. So to summarize, I think that these few cases hopefully exemplify some of the strategies that I would use. First, you need to assess the lesion morphology. Again, imaging with IVUS is very helpful. Then I would really have to acknowledge that some tools are better than others. And more recently, I would say that IVL has become a real mainstay in my armamentarium for treatment of calcium just because it's so safe and relatively easy. The downside is it's not always easy to deliver in heavily calcified vessels, and that's where arthroablative techniques are really probably your go-to. Going subintimal is easy and convenient, but sometimes limits your opportunity for debulking, and so IVL probably is your go-to strategy there. And if you're going to try to get drug-eluting technologies to work best, I do think it's important to fracture the calcium to improve the diffusion permeability of the artery. The data for that practice is not very strong, but I think it makes sense and is probably worth doing. And finally, I think that the strategy of debulking has gone away, and it's really just plaque modification to achieve adequate plaque fracture. It's going to be a multimodality therapy. It's not going to be a single modality treatment. And so you don't need to debulk a lot to get a good effect. And then editorially, I would just add that using an embolic protection device will save you a lot of anguish in the long run. With that, I'll thank you for your kind attention.
Thank you, Sahil. That was fantastic. Always good to get those technical insights. And next is my dear friend, Dr. Chris Metzger. He's going to describe his strategy of dealing with popliteal lesion. The topic says standard, but I know, Chris, it's not going to be standard. So let's see what you have to present to us today.
All right. Well, thanks, Subhash, Mehdi, and everyone for the invitation to be here. It's great to be here at CVI and talk about our standard approach to popliteal lesions. Now, here are my disclosures, which will include some things that we'll talk about during this, but from the heart, not the wallet. This is an important artery, and it's got a lot of flexion issues on it. It's often contiguous with disease above or below, and so that leads to mismatch with size. It's not only an important surgical target, but it seems to be a target for embolic events as well. And again, there are other issues, geniculate arteries all over the place, and artificial knees, which can get in the way when you're trying to work. As you look on the angiogram here, just a reminder to all of us what that artery looks like when the patient goes home and bends their knee rather than has it straight on your cath lab or OR table, which really affects how we treat this, I think. Now, I think endo is frontline for a lot of these. We have a lot of improved devices you've already heard about to prep the vessel and strategies to keep the artery open, and we have increasing collaboration and data and experience. When I look at a popliteal, I have two goals. First is the vessel prep, which you just heard about, to maximize the luminal gain while minimizing dissection. If you do that, you have a lot of treatment options available to you, so I tend to use a lot more specialty balloons and selective atherectomy, and then reevaluate and choose our definitive strategy, which is designed to maintain long-term patency. And that's, for me, is either going to be a DCB usually or a Sapera interwoven stent, occasionally the other stents listed there. Our strategy is going to be affected by a lot of things. It's individualized, vessel size being a big one, the amount of disease above or below, and especially to trifurcation, what's in and around the vessel, thrombus, calcium, et cetera, and some of the unique things that happen popliteal, like aneurysms and others. Because of this, I have a toolbox of things I use more often, or tools I use more often with a popliteal listed here, which include the reentry device with a Pioneer, and I'll show you in a moment, as well as Penumbra and the IVL and some of the things you just heard about. I think there are sometimes you really don't want to stent, and that would be especially true for smaller popliteals. I love the Sapera, not a 4.5. I will never put a 4.5 in again. I promise you those patients will haunt you for years with restenosis. So don't do it. 5 occasionally, but almost always you can make it a 5.5. If you have to go small, use a DCB. And some of the other trifurcation issues you wouldn't want to stent. And you for sure do not want to stent a popliteal entrapment or cystic disease. Those are surgical, not stenting. Now, what about stents in this traditional no-stent popliteal? Yep, if it's the right stent done correctly. For me, it's Sapera interwoven stents or the Frontline, and occasionally Viabon or DES, never nitinol stents for me. Why? Because it's 4 times stronger and yet conformable and fracture-proof. So I want to show you some cases to take through these strategies. Here's a simple one. Discrete popliteal calcified lesion, very easy. So what do? IVL with a 6.5 balloon, and look, no dissection. Now your options are wide open. Prolonged drug-coated balloon with a 6.0 DCB, and nice result. Didn't have to leave anything behind. Nice result, good runoff. This one came on fairly suddenly, the symptoms, and you can see both the occlusion in the popliteal and the TP trunk. So based on that, we crossed that and did laser and restored flow in the pop. And then again, long drug-coated balloon, cross that TP trunk, similar strategy, and you can see nice result, again, with your preparation and DCB, nothing needed inside there. Now, moving on, this is, Sahil, you'll recognize something like this, heavy calcium. You can see occlusion and then microchannels after that reconstitution, and tibial disease. For microchannels, I like 014 wires to cross. This is like you said, and I agree with your editorial comment, distal protection. And this is a 017 Viper tip wire. Here's the CSI done slowly in the heavy calcium in the popliteal. DCB after angioplasty, and Sahil's right. This is why I use this thing. Okay, no flow after that. Now I would use Penumbra to retrieve it. This was back in the day, so this is just a second wire into the basket, an aspiration catheter into the basket, and then take the basket out. And this is why we use them in this scenario. That's what we got in the aspiration catheter. After that, you see what we had in the basket, and simply getting that out led to a nice result and complete restoration of normal flow without distal embolization. All right, now let's move on to stenting. This is a good case for this is calcified SFA occlusion, contiguous with disease in the popliteal, long disease. So after pre-treatment, you can see the Supera stent, and you can also see how beautifully that stands up to calcium, all the way down in the popliteal without post-dilatation. But more importantly than this runoff, the runoff's nice, and even in that calcium, this is why this is a popliteal stent. It stands up to calcium but bends with the leg. This is just the vascular mimetic properties of that. Similar case, this is a 7-year occlusion of a pop, and it got TP trunk disease as well. We crossed that, tried to preserve that bifurcation, lasered it, but you can see that there's dissection there, and it was true by IVUS as well. I was hoping the angioplasty, we actually had to put a DES in the TP trunk. Now, this is important. So here's still residual dissection. I really think we needed to stent that, so it's going to be an interwoven stent. Very importantly, if you're going to do that after DES, you don't want the nose cone of the Supera going into the DES. So note that we switched our wire position into the anterior tibial so we don't distort the stent when we put the Supera in. The other way to do it, put the Supera in first and then the DES either way, but don't ding up your stent. And again, nice bent knee angiogram and nice runoff. These doggone knee replacements, I think orthopedics like to do this to us. I really do. They put it in the right, the occlusion right where the knee joint is. You can bend the knee and bend your cameras, but sometimes it's still hard, and you can see that we're not quite there. We're real close. This is a beautiful time to use your Pioneer, because what you can't see through the knee joint, you can sure see with your ChromaFlow and your IVUS. Boom, first stick, get into the vessel, and finish the job. Again, bent knee angiogram and nice runoff, despite the orthopedics. Finally, sometimes you're going to have aneurysmal disease. This is a live case we did recently. You can see it's a combination of calcium and 2.1 aneurysm and stenosis. We always use IVUS if we're going to Viabon. And so this was shockwave first, followed by a Viabon and angioplasty. And often I've gotten in the habit, now we have 7.5 Superas. I like to reinforce those sometimes to protect them from getting infolding later when patients go home and bend, and there's the final result in that case. Last case, this is somebody who came in with a subacute limb ischemia. You can see the popliteal occlusion right here. Put a lytic catheter in, came back. And what we found was that the etiology, that was an aneurysm that was there. And this is after some work, then we marked it, both sides, put a stent graft in, and he did very well with that. But as often as the case, not often, but it happens, as everybody knows, with the Viabon, sometimes they will occlude despite medical therapy, which was the case here, so another lytic catheter. And again, after that, we used the 7.5 Superas, reinforced it. And then finally, again, you can see the clot there downstream at the trifurcation in a full basket. Again, I agree with Sahil's editorial comment. So here's where a penumbra is great. A Cat 7 Lightning, you go down and take care of the thrombus, and you take the basket into the device and take it out safely, and with that, complete resolution of any thrombus. So in conclusion, I think popliteal lesions can be treated effectively with endotherapy in the majority of cases if you use an individualized, collaborative approach, maximizing safe luminal gain with vessel prep and then anti-restenotic therapies and strategies. And for other Pittsburgh fans, thanks for your attention.
Thank you so much, Dr. Metzger. We are obviously running a little bit behind because of the earliest, late start. But let me ask Dr. Farber a question related. We discussed kind of the aortic pathology and treating dissections. We talked about aortoiliac disease. My question to you is that from a standpoint of the task classification and aortoiliac disease, what are your thoughts in regards to first-line therapy? Are you always going with endo first, or are there patients that you would consider for open? Give us your thought process about aortoiliac occlusion and task D.
Sure, happy to do that, and I'm going to talk a little bit about it tomorrow as well. Certainly, endo first is the right approach in aortoiliac disease, no question about it. Some exclusions are when you have severe aortic disease, if there's an aortic occlusion, particularly if it goes up to the renal arteries, I think those people are better treated with with an aortobifemoral bypass only if they're candidates. But there's no question that for task A or B or C, we do everything possible to do it endovascularly. Again, but there is an option for those people who are candidates for surgery and who have extensive, primarily aortic disease.
Alec, if there's calcium in the common femoraries, does that alter your approach too? Do you tend to go more surgery there, or do you do cut downs and then endo, or do you combine an aorta iliac, or excuse me, aorta femoral with an endorectomy?
Yeah, I think that's a great point, Chris. Certainly, if there's severe common femoral disease, or even moderate, it's tricky to do it endo through the groin because there's a risk of an occlusive situation, an acute limb ischemia, that sort of thing. So in those situations, we typically open up the groin, open up the artery, do an endorectomy, and then do it endo up higher.
No, go ahead.
Let me ask one more question, Dr. Ramon Varcoe. I guess in that spirit, how would you compare, we have a lot of, obviously it's a multi-specialty meeting, how do you compare endovascular approach to, let's say, AXFEM or FEM, some of these extra alternative, revascularization techniques? When do you go to like an AXFEM or a FEM approach versus, endo? Is it after you fail and the patient is not a candidate for aorta by FEM?
I'd have to say the short answer to that is rarely, Mehdi. There are certainly cases, like Alec mentioned, that are probably preferable for surgery, but we would still favour an inline anatomical approach to surgery with an aorta by iliac or aorta by femoral device. I don't really like putting prosthetics into people wherever possible. So I try to avoid that at all costs generally. Even with infected aortic grafts that need explantation, I will still go more for a neo-aortoiliac procedure than I would for an AXFEM.
Okay, for the sake of time, if that's okay, we're going to have discussion at the end, which is going to actually, probably we can combine some of these other presentations. I'm going to invite Professor Zeller. He's going to be discussing acutely thrombosed lower extremity arteries. Thank you, Professor Zeller, for coming all the way to us in Denver.
Yeah, well, Mehdi, Subhash, thank you for inviting me. It's a pleasure to be back here. And, it's not my typical topic I'm talking about. These are my potential disclosures, but nothing is really related to this particular talk. I would like to start with 3 case presentations where I believe it's showing the value of mechanical thromboatherectomy. So the first one is a patient with instant reocclusion of the left common iliac artery. What you can see over here, there's some reconstitution of the internal iliac artery, some mild outflow via the left external iliac artery. And important to note is there is thrombus in the bifurcation. It's sitting in the bifurcation, and this is very at high risk for distal embolization if you touch this area. Of course, you can consider direct stenting to fix this thrombus, but anyhow, this is something you have to be very careful in treating such kind of lesions. And what I did here is I'm a fan of Rotarex mechanical thrombectomy. I've experience with this device since 1989 now, so it's a couple of years, several thousand cases in the meantime. And here I used the bilateral femoral approach, and the retrograde approach was using an 8 French access with the 8 French system, and I simply did clean the common iliac with mechanical thrombectomy. And what you can nicely see, the bifurcation is fully cleaned from the thrombus, which was initially riding on the bifurcation. And this is due to the high suction capacity of this particular catheter, that the thrombus is also sucked out of the bifurcation. And finally, there was kissing balloon angioplasty performed using a DCB in the left common iliac artery. The other case is showing again an instant reocclusion, a very tiny SFA and a grade 6 French excess here to the left SFA. What you can see over here is this mismatch between the lumen of the patent SFA and the popliteal segment, which is related to an arithmetic deformation of the popliteal artery. Several former intervention had been performed here, multiple layers of superior and viable endoprosthesis. There's also some drug-eluting stents in the TPT going into the peroneal artery. There was a very, very faint filling of the outflow, almost nothing. Patient came in with rest pain. This is a 6 French Rotarex system, which was applied down to the popliteal into the anterior tibial artery. This is the result after one single rotational thrombectomy passage here with complete reopening of the distal SFA, the popliteal segment, including the wire band and including the origin of the anterior tibial artery, which is still stenotic, of course. Then drug-eluting balloons had been applied. With this final outcome result. Some residual stenosis in the distal SFA was left. Patient was recommended to use oral anticoagulation combined with clopidogrel. And this is the outflow, so there was no acute embolic event. The dorsalis pedis artery was already occluded before this procedure. And the last case example is a patient with atrial fibrillation, distal embolization, so this was a cardioembolic event, typical angiographic appearance, distal occlusion of the popliteal, including the origin of the anterior tibial and the TPT, which was treated with 2 passes of the Rotarex system. So what's the background of this technology? That's the Rotarex catheter. It's, in my experience, the most powerful thrombectomy, probably also in some way as rectomy device. It's consisting of a catheter including this helix, which is rotating with 36,000 beats per minute, and by this creating a very effective suction capacity. And it's consisting of 2 parts. The helix is connected with a tip with side holes, which is rotating around the so-called stator with sharp edges, and all the material, including organized thrombus or even as aroma, is then fragmented and sucked into the catheter and transported outside into a collecting bag. And these are the indications. So the device is basically indicated for every occlusive lesion you are treating in the femoral popliteal segment, as long as you are staying in the true lumen. So if you can apply this device in the true lumen, you can even treat chronic total occlusions. And this is a very early experience. This is a publication of my first 100 patients. And you can see the date of the publication, 2002, very early. And this is comparing the outcome in de novo lesions, where this is group 1, where the device did work very effective, combining it with plain balloon angioplasty. The problem is that rotational thrombectomy does not solve the problem of instant reocclusion or bypass reocclusion. Therefore, you need to apply local drugs like with DCB or DES, and at that times this was not available. So at the end, at 1 year, restenosis rates in these both pathologies was more than 80%. This is recent published data where the authors did compare the outcome of Rotarex thrombectomy with historic data from local lysis and surgical reconstruction of thrombotic occlusion, and you can nicely see over here that the acute success is much higher than with surgery or with thrombolysis using rotational thrombectomy, and also limb preservation is better. Even if this is not direct comparison, it clearly shows that this is a very, very successful treatment opportunity for thrombotic lesions. This is a study from Leipzig. So far the largest published paper. More than 500 patients had been enrolled, mostly subacute occlusion, about 60%, and lesion length was really relevant. And you can see that standalone rotational thrombectomy or a combination with balloon angioplasty was done in about 2/3 of the cases. Only in 30% additional provisional stent placement was done, or in 14% additional local lysis, in particular in cases where distal embolization was present. And this is procedural success in line with the published data from the previous study, almost 98%. And these are the outcomes regarding safety. You can see major adverse event rate pretty low. There was no mortality related to the device, and this is 1-year outcome. Freedom from reintervention extremely low or high. It's a TLR rate of only 10%, which means that potentially mostly de novo lesions had been included into the study. Here, this is a prospective study investigating the performance of Rotarex in acute and subacute occlusions. 300 patients had been enrolled into this study. And you can see that the reason for treatment was in the majority local thrombotic lesion. Only in 60 out of these 300 patients it had been embolic origin. Again, very high success rate, in this case 100%, a low complication rate, which was mainly related to additional local lysis after mechanical thrombectomy, and these are the early results. And finally, the 1-year results, freedom from amputation, 87%. And finally, the topic of this talk was treatment of lower extremity acute occlusions. You can apply this technology also to embolic occlusions of the upper limbs, like here. This is also cardioembolic event occluding the subclavian artery, and this lesion was treated with an 8 French system, and this is the outcome result after rotational thrombectomy. So in summary, mechanical rotational thrombectomy is my first choice. Endovascular treatment in acutely thrombosed peripheral arteries. Additional local lysis is limited to a few cases with diffuse peripheral embolization resistant to low-profile aspiration thrombectomy. I usually use straight guiding catheters for distal aspiration procedures. Additional stent implantation may be indicated to fix organized cardiac emboli resistant to local lysis. Thank you very much.
Thank you, Dr. Zeller. That will be fantastic. We'll have more questions for you during the panel discussion. Let's move on forward. I think we have discovered many different areas of interest, from dissections to calcified lesion, popliteal, and DCBs, and now we're going to get into the CTO crossing mode. And to do the first presentation, invite Dr. Nicolas, my dear friend from Midwest Cardiovascular Institute from Davenport, Iowa, to talk about his step-by-step approach to aortoiliac CTO crossings. Nick, thanks for being here, and invite you to. I'm looking forward to your talk.
Much. And thank you, Mehdi, for the invitation too. All right, so let's see. So these are my disclosures. Okay, you already have seen this many times during this morning talks. The task 2 aortoiliac disease classification. It's really important to be familiar with this. You know, as you know, type A, B, and C, as we have heard from the panel, it's an easy treatment usually for an endovascular approach. I wouldn't want to say easy, but it's definitely amenable for an endovascular approach. You know, we talk about the task D, and we're doing a lot of those task D from an endovascular standpoint, but I want you to keep in mind that the surgical option is really not off the table. You know, many of those patients still are very much amenable to the surgical approach. So again, I personally do a lot of CTAs on my patients. You know, I find it extremely useful, you know, to determine the map of what I'm dealing with before I get into the case. You know, it helped me plan my approach, not initial plan, but second plan and third plan. At the same time, it allowed me to identify the tools, you know, that I need, you know, to treat the lesions. I want to make sure that I have every single tool, you know, that would allow me to at least tackle complications. This is an area where complication can be extremely dangerous. You know, a perforation, you know, a patient can start crashing right in front of your eyes, so you have to be ready for this. Again, knowing when to stop is important when you treat complex aortoiliac disease. Again, the value of CTA is determining vessel size, looking at tortuosities, determining the severity of calcium, looking at the location and the length of the occlusions, the presence of prior treatments, the cap morphology. All this will help you in having a smart approach to your case. Again, for instance, here for access, you can potentially get away with a single site access, via an ipsilateral or contralateral approach. Sometimes even short occlusions are very difficult to cross, and you may have to have a bilateral access to do this, or sometimes radial and a pedal access. Again, you can have dual or triple access, when you start dealing with more complex disease. And I would always keep the surgical option for the very, very advanced disease, particularly the aortic disease and origin of the common iliacs, and especially if you have a high aortic occlusions. So you need to be familiar with the CTOP classification. You can see that would help you determine where your approach will come from. A retrograde approach, usually from the common femoral, can be good for the certain type of lesions. Many times a dual approach, contralateral and retrograde can be important. Radial, we have used those as well, as brachial approaches. And then the antegrade approach from a contralateral, access will be good. I use fluoroscopy as well as the knowledge of the CTA to tell me exactly what my access will need to be. Ultrasound can be very helpful in that situation. When you work on aortoiliac, always make sure the minimum sheath size should be a 7 French. A perforation there, many of your graft stent will not go, through a 6 French. Many times you have to use an 8 French sheath, particularly with big vessels, and you could get that information very clearly from a CTA. Always make sure your covered stent is in the lab, not on the shelf, and always make sure you know what stent you will use when a perforation would occur. Prerequisite knowledge is knowing your sheath. I would stop the warfarin and the DOAC prior to the procedure. I don't like to use Lovenox and Angiomax in these procedures. You just simply cannot reverse them. Be familiar with using the IVUS on a routine basis in terms of wire position, the vessel size, plaque morphology, stent expansion. Lithoplasty for calcified disease, really it's excellent for the iliacs. I use it almost routinely. I try to avoid atherectomy except maybe in cases like Dr. Zeller presented, a thrombectomy-like device for total occlusion with the Rotarex. Pain is a very strong indicator that you are dealing with possibly even imminent rupture, so be careful with that. So don't over-sedate your patient. Know your covered stents very well. Dr. Feldman has covered that very nicely. But just a reminder, your Viabahn self-expanding stent is usually good for the external iliacs. Always have the balloon expandable stent, mostly for the common iliacs. I like the VBX stent personally because you could expand this all the way up to 16 millimeters, especially the 8L and the 11 sizes. That takes an 8 French sheath. That's very important. The live stream can go up all the way to 12. It would need a bigger sheath, an 8 French sheath. Now, how do you cross your CTOs? Well, if it's a short occlusion, if it's a non-calcified, you may want to try an 014, Astato, like for instance, wire with a heavier tip. Using a stronger 035 support catheter. I like those. It does help in that situation. I don't put more than 12 to 15 degree angle at the tip of my wire. It helped me to maneuver that in a very precise way. Always take multiple angulation when you do this. Now, sometimes you can go up to the V18, the 018 hydrophilic, tip wire for non-severe calcification, or you could use the heavy tip wire like an Astato 30 if you have to. Many times we have to go to the 035, extra stiff glide wire, whether it's straight or angled. I do avoid wide loops. If you put a big loop in those vessels, you could potentially end up with a large space that could lead to potentially the difficulty of recrossing back. Verify always the intraluminal crossing if you can. And if you're unable to get into the lumen, of course, many times you have to use, retrograde, antegrade, dual kind of hybrid approach. Be familiar with your cart, your reverse cart, your wire rendezvous, your snares, all these you need to be familiar with. At the end of the day, if you cannot get back, you need to have a re-entry crossing device, such as the Pioneer or the Outback. I personally like the Pioneer just because of the ultrasound features, and I know exactly what I'm delivering, my needle in this case. So stenting option, you can have multiple stent option. You can have a kind of kissing stents like where you displace the bifurcation cranially, the top hat and trouser technique, parallel stent, and we've already seen the syrup technique that has been previously described. Always watch for perforation, thrombotic occlusions, and distal embolization. This is a classic example, of recrossing, with the re-entry using the outback. You could potentially do this, but don't recross too high into your aorta. Then you are reshaping completely the bifurcation and leading potentially to complications. Another example of this is the Pioneer. Always make sure that the lumen is visualized at 12 o'clock before you deliver your needle, so you can move your catheter in a way where the flow is visualized at 12 o'clock, and that's exactly when you deliver the needle. It's excellent for re-entry. I personally use it more often, and I find it very easy to use. Conclusion is plan your case. That's the most important thing. Make sure you get good imaging, understand your access, your support catheter and crossing wires, use IVUS and have a good knowledge of some techniques like the cart, reverse cart, and so forth, and understand well your Pioneer and your outback catheters. Thank you.
Fantastic, fantastic. A lot of packed information, Nick, as always, and I think some of that knowledge will be useful when applying to femoropopliteal CTO, and invite my dear friend who has traveled all the way from Australia to come to us. Not only he's a great speaker, I just love hearing him, and you will know why in a few seconds. Ramon?
Thank you,
Take it away.
Subash. Thanks for that wonderful introduction. I can't tell you how fantastic it is to be back here at CVI face-to-face in Denver. It's a wonderful meeting, and it's great that we've been able to negotiate this terrible COVID period. So my task today is to talk to you about femoropopliteal CTO crossing. These are my disclosures. None of them are relevant to this talk. So the CTO is constructed of a proximal cap, which is often fibrotic and difficult to penetrate. It also has the main part of the CTO itself, which is dominated by type 3 collagen and calcification. And it also has a thinner, more distal cap, which we can take advantage of with retrograde crossing techniques. It also has microchannels, and a skillful operator can engage these microchannels with various crossing wires and use the tactile feedback to drill through the CTO. And that's how we achieve crossing in a transluminal fashion. The way we do this is we shape the tip. It's a short angle, just a millimeter behind the tip that we make here, and this gives us tactile feedback when we're trying to engage those microchannels. So I'm going to go through some standard access approaches and then some less standard ones. The standard one would be an up and over retrograde contralateral approach, which I personally use only for patients that are obese or those that have inflow disease, either of the iliac arteries or the common femoral artery. Occasionally I'll use it for a short common femoral with a flush SFA occlusion as well. Far more commonly though, I'll take an ipsilateral antegrade approach, using ultrasound to guide a high puncture of the common femoral artery. This has several advantages. It's fast. We can take advantage of the improved pushability that this approach achieves, and we can also use shorter devices. So this is my preferred technique, particularly when tackling tibial CTOs. So you place a short sheath in the common femoral artery, and then you get on with your revascularization procedure. But sometimes an antegrade crossing is not possible, and I have a low threshold for taking a retrograde access approach. The principle here is to try to get as close to the CTO as possible. So if it's a proximal SFA CTO, you can puncture the popliteal artery, either above the knee or below the knee, depending on the extent of the SFA disease. Or if it's more distal, involving the popliteal artery itself, you might have to tackle the tibial arteries. You can place a sheath in the popliteal artery, and you can pass a retrograde wire up like this, and once you've done that, you can externalize it, either with a snare or just feeding it into a catheter from an antegrade approach. Once you've externalized the wire, you've got a through and through wire, and this gives you a lot of opportunity to push and pull and take balloons across that CTO. You then balloon, pre-dilate, use a drug-coated balloon or a stent, depending on your preference, and Bob's your uncle, you revascularize that long CTO in the femoropopliteal segment. When you're tackling the tibials in a retrograde fashion, you have to think about your C-arm placement. So if you're going to puncture an anterior tibial or a dorsalis pedis, you want to put that C-arm in an AP projection. If you're puncturing the perineal, the trick here is to separate the bones out because the perineal is very close to the fibula and you have to skirt the fibula and make sure you can see that clearly on fluoroscopy when you're doing your puncture. The posterior tibial is a complete lateral approach with the C-arm. So you can approach this in the proximal tibials, which has the advantage of being able to use short forefront sheath. When you do this, you can do it under ROMAP, you can do it under ultrasound, or simple fluoroscopy with puffs of contrast. The trick here is just to stay in line with the blood vessel the whole way down until you see that flashback. A long sheath is mandatory from above. Get as close to that popliteal occlusion as you can. This gives you support from above and enables you to use lesser volumes of contrast. And you can puncture all three tibial arteries in the proximal third of the calf. This is a nice way to do it. It enables you to use that sheath, as I mentioned before, and it's easy to seal afterwards with a blood pressure cuff. This is an example of a recalcitrant popliteal, a CTO, and here we've punctured the proximal third of the anterior tibial artery. It was very difficult to penetrate through that calcified CTO, so we've used a balloon to stabilise and enhance the pushability of the wire from below. And after externalising that wire, you can see we've delivered the revascularisation technique from above for a pretty good result, given the difficulty of that lesion. If it doesn't work simply by crossing from below, which it very often does, you can then employ various techniques. One is the CART technique, combined antegrade retrograde tracking, where you've got wires from above and below. And in this case, you're using a balloon from below to try to create a space that you could pass your antegrade wire into. This can be done with a balloon from above, and this is termed the reverse CART technique. And if that fails, you can use the double balloon technique where you've inflated balloons from both above and below. And the idea here is you're trying to melon seed the two balloons and push and tear that membrane between the two subintimal passages. Finally, if that doesn't work, you can inflate a balloon from below and use a re-entry device such as the Outback or Pioneer catheter to puncture that balloon and introduce a wire into the punctured balloon space, which you can then use to track down from above. There are a couple of less common approaches I also wanted to mention. One is puncturing an occluded stent, so an in-stent restenosis or re-occlusion. These are fairly easy to puncture because they're visible on fluoroscopy. You start off with an AP plane and just a simple 19-gauge crook needle, puncture into the stent itself, then reposition the C-arm to a lateral approach, and at that point you can see a loop of a standard stiff glide wire, pass that up from below, recapture it from above just like you would normally, and then you can pass a catheter down from the antegrade sheath into the mid portion of the stent. You can then reverse the wire and complete the transition of the occluded stent down into the popliteal segment, and then you can get on with your revascularization. Another less common retrograde approach is the profunda access from retrograde. You can puncture the profunda either using ultrasound or angiography, depending on the size of the person's thigh. This is something that I've done multiple times. It's a fairly easy retrograde puncture, and it's useful for a flush occlusion of the profunda. I use a micropuncture needle, and then I usually replace that with the micropuncture sheath that comes in the kit. You can attach a check flow valve to that, and you can use a variety of low-profile wires and also crossing catheters from that retrograde profunda access. Then you have a through-and-through wire in the same fashion as you have from a retrograde, more distal puncture, and you can get on with your revascularization. Here's an example of a flush profunda occlusion with two main profunda branches, each of which can be punctured. Here we've punctured the more distal of the two. You can see the two wires here trying to rendezvous. Crossing from below in a retrograde fashion, you then externalize that wire, and you can see here that's an injection of contrast through the retrograde sheath. After crossing, we've selectively cannulated the more proximal profunda branch as well, and we performed kissing balloons and stents here to get a nice revascularization of the profunda artery. So in conclusion, treating CTOs requires good knowledge of equipment, including guide wires and crossing catheters. You've always got to pre-plan your approach to these more complex cases, as we've heard from the other speakers, and consider an early transition to retrograde wire tracking wherever possible. Thank you for your attention.
Fantastic. Fantastic. You know, Ramon, you have done something really good with these graphics because there's a lot of confusion of terminology. And I think these graphics help clarify. I'm sure there are many in the audience. So I can tell you, Tino, that despite years of practice, I'm sure my colleagues do significant variability in BTK crossing compared to femoropopliteal. So I think although Ramon covered some of those tips and tricks, I'm very, very sure that we are going to hear something more, something innovative and something what Tino does in his lab and how he manages and tackles BTK CTO. So take it away, Tino.
Thank you very
Thanks
much,
for being here.
Subhash. Pleasure to be here. Great talks. I think we're going to continue on the similar path. Perfect. These are my disclosures. Can you hear me? Perfect. So obviously the importance of occlusions and crossing them cannot be overstated. I'm going to start just with a general idea, and I think we've heard of it from the last two speakers. You know, as we approach it, you know, are we accepting a subintimal path? Most of the time we will. We'd love to say intraluminal, and it's hard to know. Now with IVUS gives us a better idea. When to use a device, when are you going to use a reentry device? And I think it's really important to have an idea of time, how far are you willing to extend a dissection, how much contrast are you willing to use, and what's your profile in terms of accepting a complication. Obviously, I think that is much lower in the aortoiliac segment than it may be in the tibial segment or in the femoral popliteal segment, and knowing when to stop. In terms of tibial crossing tools, I think here we're looking at an 018, 014 crossing system. I particularly like 018 catheters and 014 wires. The 014 wires give me the ability to use both 018 and 014 balloons, while the 018 crossing catheters give me a little bit more pushability. In terms of wires, I prefer the jacketed wires, sort of like the Gladius, and I still like the soft angled glide wire. I think I can buckle that very easily, and sometimes it can help me get through and find alternative pathways if I find myself in a subintimal path that I don't like. And then I will escalate to stiffer wires. I think we've already heard about the importance of going antegrade, and always go antegrade ipsilateral if possible. And I'm not, and I will go ahead and do an SFA puncture if necessary. A lot of times I can do these procedures with a 4 French sheath or a 5 French sheath and proceed from there. And I think that's important to have in mind. When you look at a crossing at BTK, I think if there's a lumen, you may be able to just get through with a hydrophilic wire and a catheter. And I think that's hopefully what we hope to find. And a lot of times that's usually what we start with, particularly in short occlusions. As you start going to harder or more difficult type occlusions, particularly calcified occlusions, then you start thinking about, okay, am I going to get subintimal? Am I accepting that? Can I re-enter? How much radiation, how much time am I willing to spend until I decide to then go retrograde or in a re-entry device? And I think in the tibial occlusions, I prefer to go retrograde and start with that and try to then see if I can re-enter. Here's a case of an 83-year-old non-healing first toe amputation and a worsening ulcer now on the second toe. You can see that really has a perineal single vessel runoff to the level of the ankle. Then you see it fill the plantar arch through collaterals. But really, we wanted to see if we can get the anterior portion of the foot open. Looking at the AT, you can just hear a simple wire recanalization, a 018 wire with a 018 crossing catheter, able to cross and get into the DP and then treat with prolonged angioplasty with a good result. But what about advanced techniques? And I think reentry, we've heard about reentry. We've heard already about the STAR technique or subintimal tracking and then reenter. And I think that's really my number one attempt. I try to go antegrade. If not, I will go ahead and try then buckle my wire and already have an idea how far down am I willing to go. I think the secret here is to keep that curve, that buckle, as small as possible and see how you advance in that subintimal plane. Sometimes calcified lesions are going to be a lot harder to be able to do that. As that happens, then try to limit to try to get back in. If that's not possible, then have really a short idea of where I'm going to go retrograde. And a lot of times, I think the key of tibial crossing tibial vessels is already have an idea which tibial vessel are you willing to go antegrade and retrograde from. And maybe that's the one you start with. Already have that decision tree made in your mind. And then go to more advanced techniques such as cart and reverse cart that I thought Ramon showed really well. We came up, and I know Subhash published this in terms of a group of us, in terms of different algorithm, and I think it's really similar to what we just talked about. Going antegrade, knowing your cap morphology, understanding where you can go retrograde, and then going from there with these advanced techniques. And again, this is that algorithm that we use. Here's a case, a difficult case. We had antegrade access, weren't able to recanalize this anterior tibial, then went retrograde, and you can see here 2 catheters in the anterior tibial artery. And again, we're in 2 subintimal spaces, but we're not connecting. We're unable to really cross these. We use some balloons, and a lot of times I'll use a balloon from one side, and then if that doesn't work, I'll use a balloon from the other side, and trying to create that tear in that subintimal space. I think what I've learned is use bigger balloons. In this particular case, I probably used a 2-millimeter balloon. I probably gone to a 3-millimeter balloon to try and create that tear. And the longer, and that's really where the size of your buckle is important. Once you create a larger subintimal space, it makes it harder to connect these subintimal spaces. And you can see here afterwards using a snare. If that's not successful, a lot of times I may go to one edge or the other edge of that subintimal space. And understanding where you've created that subintimal tear, I think is helpful to knowing where you may be able to connect them. A lot of times gentle injections here are somewhat helpful. You can do an injection, you can see, wait, I'm connecting to the lumens are connecting up in this area, and that's usually where I go and try to snare the wire. And if that's not helpful, then I'll use this type of technique with an outback device and a balloon, and I'll actually puncture the balloon and then get the wire into the balloon and then pull the wire out through my retrograde axis and externalize it. And then from there, be able to use a balloon and angioplasty. So in conclusion, I'd say crossing vessel occlusion is obviously the most challenging part, I think, to below the knee, and a lot of the procedures we do throughout the peripheral system. I think having a technique based on how you're going to escalate is important, and applying that technique to that particular patient, particularly the tibial vessels. Where are you willing to puncture? Where are you willing to go retrograde? And having that ahead of time, I think, is the key to creating a firm strategy and being efficient and effective. Thank you very much.
Thank you so much. Tino, take this microphone and sit right next to Thomas and Nick. So we have a few minutes for a rapid-fire question. We are not going to let this masters panel off without making some commitment, starting from left to right and here, and then to Shirling, Thomas, Tino, and to Nick. I'm going to ask 2 questions, so rapid-fire. So tell us about your % use of atherectomy, and of which of these devices you use most, is your first go-to, that is ablative, IVL, directional, high-pressure balloon, or a scalpel? And the second question is % use of intravascular imaging in your cases. Start with you, Ben. Rapid fire.
I'd say atherectomy, very low use, but I do use intravascular lithotripsy a fair amount.
Give a number, but percent numbers.
Probably 30% of cases using shockwave.
30% atherectomy, IVUS use, not much?
IVUS, probably 10%.
10%. Ramon, quick fire, rapid fire.
We don't use much atherectomy. It's not reimbursed in my country, and there's no real good evidence for its use, so we don't do it. IVL we use very specifically for high calcified cases, which is a small proportion, maybe 5 to 10%. And intravascular ultrasound we'll use pretty much routinely to help with sizing and understanding the pathology.
Fantastic. Chris?
Atherectomy selectively, if there's a good reason, probably 10%. And IVL, like you said, if there's heavy circumferential calcium, bigger arteries coming from our iliacs all the time, I use it a lot. And IVUS, if there's something I need to know. So I just guess 25, 30%. If I'm in trouble, I use it.
Fantastic. Sahil?
Yeah, I'm pretty similar. I think that probably atherectomy now is down quite substantially, like to 10% or less. But IVL has made up the balance, so about 30, 35%. And we like to image in our place, so it's probably over 50% IVUS use.
Alec, but you can't pick the scalpel as a choice.
Right, no scalpel. Less than 5% atherectomy. We're trying to get IVL into our institution. We don't have it yet. And for large vessels, I use IVUS routinely.
Fantastic.
Yeah, orbital atherectomy is a go-to for calcified lesions before. Right now, it's probably 5 to 10% use. Like people said, IVL has taken over, so probably 30 to 40% IVL. IVUS probably not high enough as it should be, 10 to 10%, but steadily increasing.
Mehdi? Go ahead, make a commitment. Thomas, your choice.
Yeah, well, if I, well, let's say combining mechanical thromboatherectomy plus atherectomy, it's about 20% of the cases. IVL in calcified lesions, 20-25%, in particular in those with concentric calcification, and IVUS never.
Dino, yours?
Yeah, very little atherectomy. I think we're using a little bit now of the Rotarex and in-stent restenosis, and that's one of the areas that we've kind of used a little bit more of the atherectomy. We're using a lot of IVL, particularly in big vessels, iliacs, common femoral, places I don't want to stent for sure, and IVUS, I think we use very minimal IVUS really when we have a question.
Fantastic, thank you.
Well, it must be quite different from the entire panel here because I do atherectomy in at least 45% of my patients, 20% or so IVL, mostly, of course, the severe calcification. IVUS, very heavy on IVUS, especially in the infrapopliteal territories, and I would say at least 60% of my cases uses IVUS. So
Tino?
completely the opposite direction.
No, thank you. Tino, can you carry the microphone to Shirling, please? Thank you. Shirling, your commitments.
Yes. So very little atherectomy, almost none. IVL we've actually started using a lot of, maybe like 30 or 40% for our really calcified lesions. And IVUS, probably should use it more, but I use it a lot for bypass graft stenosis or in-stent stenosis, especially when I'm looking at lesions that I've seen with high velocities on duplex, and we don't have like previous imaging, and I'm trying to figure out how much stenosis there really is.
Thank you.
Okay, I'm going to ask a similar question in a different spirit. For lower extremity PAD, in the last 5 years, give me one device that you believe has had the biggest impact on your practice. And I'm going to start with Dmitriy this time. So in the last 5 years, for lower extremity PAD, give me one device that has had the most impact on your practice.
I'd say it's a tough choice between DCB and IVL, but probably DCB would take the cake.
Drug-eluting coronary stents and tibials.
Yeah, I would say long shaft, low caliber wire drug-coated balloons. We use them in almost 100% of our cases.
I'm going to cheat and say IVL and Supera stents.
Probably for me, it's wires, like the new range of Asahi wires, and in combination with non-compliant jade balloons has really made a big difference in my tibial practice.
I agree. DCB is probably the main thing in my practice, and as far as techniques, pedal access, including primary pedal treatments with no femoral access.
Well, you asked during the last 5 years if the period would be longer. It's definitely DCB because DCB is really a game changer. If you limit it to 5 years, then it's IVL.
Yeah, I would agree. I would say the same thing, DCB, IVL.
I think we're on the same page on this one.
I think the access for the pedal access is really amazing.
It's a classic Subash. But anyway, I think we are over the time. I think we are over the time by 4 minutes. It's lunchtime. I just want to thank again our panel, everyone who has traveled, and just so nice to see the audience. Just nice to see everyone. This was just a warm-up for us. As you know, many of these topics we're going to discuss in more detail in the next couple days. And looking forward to seeing everyone. There is a lunch symposium that are going to be going on, but I think that in the first couple pages you have a list of them for those that are interested. And then the afternoon session starts at 1:30 for those interested in vascular. The topic is going to be vascular disease therapies, established and upcoming. So a little bit innovative, some of the cutting edge technologies coming up in the afternoon. Thank you, everybody.